Welcome to the Egg Whisperer Show. I'm Dr. Amy. And if you've ever felt like your fertility journey raised more questions than answers, today's episode is for you. The title of this week's episode is Beyond IVF, PCOS, PGT-P, Rapamycin, and the Palter Fertility Method with Dr. Steve Palter. Today, we're talking about what happens when fertility care goes beyond quick fixes and becomes true detective work, including how metabolic health, emerging technologies, and personalized diagnosis fits into modern fertility care. I'm honored to welcome today's guest, the founder and medical and scientific director of Gold Coast IVF in Woodbury, New York. He is internationally recognized as a leader in fertility treatment, advanced endoscopy, and surgical innovation. His work focuses on uncovering root causes of infertility through what he calls the Palter Fertility Method, a systematic, personalized approach to diagnosis and care, including metabolic health, surgical precision, and emerging reproductive technologies. Welcome, Steve.
Amy, thank you so much for having me here. It is a pleasure to connect finally with you on video, and it's just so exciting to come chat with you.
Thank you for being here. And you've had such a long and influential career in reproductive medicine. And I think a lot of patients listen to what you say and take it to heart, and they take it back to their doctors and it informs their care. So you're doing amazing things. What first drew you to fertility care? And what made you to commit so deeply to solving complex infertility cases?
From when I was a little kid, I knew I wanted to be a doctor. Probably when I was in fourth grade, I was obsessed with biology and seeing people that were sick and how a doctor could heal them. That was just transformative to me. The idea of understanding how the body worked and then figuring out a problem and fixing it, what I was so driven by back then and has become a foundation of how I practice now. And I had this path really charted where I was going to go to medical school, and I thought I was going to become some sort of endocrinologist, neuroscientist. My father was a psychologist, and I was really fascinated about how the mind worked and heard about hormones and that there was this thing in your body that could affect your behavior. And so I went there right out of high school, 2 years, finished college and was in med school and said, I'm going to become this endocrine neurologist. And I started doing research and working with the endocrinologists, and I saw what they were managing was chronic disease and doing it poorly. They had diabetes and thyroid, and they were frustrated. They said, no one listens to us. We can't fix anything. It's just really fascinating biology, but people don't get better. And then one day I walk into an operation, and they're doing a laser laparoscopy and removing endometriosis. And they're like, we're going to get this woman pregnant and she's going to be able to have a child. And I was like, what kind of magic is this? And I said, but I love hormones and fixing biology. And they were like, yeah, this is where that happened. So I went back to my mentors and said, hey, I think I want to become a gynecologist. And they were like, everything that you want to do to help people change their life and work with patients that are motivated, that will do anything to see the miracle of life, to understand psychology and anatomy and physiology and solve problems and then create the miracle of life. They said, you should be a reproductive endocrinologist, not a medical endocrinologist. And from that day forward, I started running seminars. I was a med student. I found a guide and I called every reproductive endocrinologist in Boston because I wanted to meet them all. And I started doing seminars, and that sort of led to this path that never changed.
Oh, I love that story. Similar to mine, but funny thing, my father was an OB-GYN, and he used to say that he was really a gynechiatrist because so much of what we do has to do with psychology. And you often describe infertility as a multi-level disease rather than a single diagnosis. So how does that perspective change and shape the way you practice medicine today?
I do a lot of teaching online on social media, both for doctors and patients. One of the things I always say is, if everyone in the waiting room next to you has the same diagnosis and the exact same protocol and the exact same treatment, something's getting missed. We have this really complex biology here, and it's usually multifactorial. Patients, this, but a lot of patients get confused. They think, am I fertile or infertile? And they just say, I just want to know, can I get pregnant? And we think more of fertility as, you have your maximal fertility down to zero. And what we treat often is subfertility, where it's going to take years and years and years without help. And if you look deep enough, a lot of things that are called unexplained actually have diagnoses, and a lot of things that are diagnosed have multiple causes, but you don't stop looking when you find the first one.
Unexplained is one of the most frustrating diagnoses that I see when a patient comes in with that because I know that there's no such thing. There's always an explanation. And you created the Palter Fertility Method. So tell us more about that and how that solves for gaps in traditional fertility care and what made this approach necessary.
So after I did my fellowship at Yale. I stayed on there. I was the clinical chief of infertility, and I had a department. We had a lot of basic scientists. We did great work, but I was the clinical problem solver. And I would look at everyone's cases and I would try to figure out what could be missed. My obsession in life is understanding how things work and fixing problems. So that led to me developing the system that I would teach to doctors and I teach patients online is you start by, it's a root cause analysis, but never assume that you're finished. It's a constant iterative mechanism to reassess and go to improve what you're doing. So, when people get jaded, doctors, they'll say, I've seen it all. I can tell within 5 minutes of the patient walking in what's wrong. And what we learn when you get experience is the more you learn, the more questions you ask. What if or why? When something goes wrong, I always say it's never unexplained and it's never just bad luck. There's always a root cause, but can we find it? So the Palter Fertility Method started with getting this, we call it the diagnostic deep dive. Like you don't stop at the first or easiest diagnosis. It's what is the entire spectrum of diagnoses that could be made. And you don't take any bit of information for granted. So very often patients will say, oh, I've had that test and it was normal. And you go back and you look at the records and you realize it was never done or it was misinterpreted. The x-ray that was normal, when you look at the films and you see it's not normal. So you start with this diagnostic deep dive, and that includes part of the frustration of people we have in our field, the patients, is years and years of trying and failure, and they think I'm just going to fail again. And what I say to them is like, let's flip that script, that everything that hasn't worked is the raw material for us to do detective work and figure out what needs to be changed. So if you've done 10 cycles, let's go through all 10 of them and say, were they ideal? Or what did we learn from them? What's the diagnosis that you didn't have? Or what's changed? Maybe you had PCOS 20 years ago, but now you've got low egg reserve because you're 45. So that's the diagnostic deep drive. And then we make what we call a success map because everyone's path really is different. The goals that patients have of how many children they want and how quickly they want to get pregnant and what other health issues have to be optimized are totally individualized. And then I think the most key part is what I call a success spiral, in that each iteration, each treatment, you're constantly like every day while that patient's doing monitoring or testing, I'm looking at the results and saying, what did I learn new that I didn't know? What can I modify? Where could I have missed something that we now know? And then either you hit it because you've been so thorough up front, you're not taking the middle of the road easy approach. You've done all your diagnostics. You do the best treatment, you get it right. And if not, we regroup and say, okay, now what did we learn how to do differently? And that's sort of it's this spiral to success, all based on learning what's truly happening.
Yeah, so patients have to go with the flow and take each experience as a learning experience, even if it doesn't work.
Yeah, so this classic work about mindset, the fixed mindset is you got a good hand or a bad hand, and anything that's hard work is tiring, and anything that doesn't work is proof of failure. And a growth mindset says everything is a learning experience and an opportunity for growth. Every obstacle you have is the key to your success if you analyze it.
And I frame it in a very similar way. And I say things like, this didn't work. And we had to have this experience because we're going to eventually get to what will work because of what we learned from this cycle.
Yeah, and I get so frustrated when I hear people say, because I get hundreds, if not sometimes 1,000 messages a day on social media. And so people will say, they just said it's bad luck. Let's just do the same thing again. And after we'll do X 3 times, Y 3 times. And then when that fails, then we'll regroup and figure out what's missed and say, no, the answer is there. We may not always find it, but if you don't ask the question, you'll surely never find it.
Right. Yeah. Asking the why is so important. So I want to talk a little bit more about PCOS, and you've done extensive work addressing PCOS through a metabolic lens. Can you explain how insulin resistance and metabolic dysfunction impact fertility and how modifying diabetes-focused approaches for fertility changed outcomes for your PCOS patients? And what do you do for them?
This is great. We could spend the next 3 days talking about PCOS. And so let me just frame it in why this is so important. Polycystic ovarian syndrome is now the number one cause of infertility in the United States, and it is one of the only ones that's rising. It used to be 5% of the population, and now it's 15% of the population. And it is an entire body disease. So it's not just a reproductive disorder where you don't get pregnant. It is, I call it now diabetes of the ovary, because insulin resistance, where your body needs to put out more and more insulin to keep your blood sugar normal, is at the root cause of most people with PCOS. About 80% of women with PCOS have insulin resistance, and 50% even if they're thin. So the mistake in the past was we thought of PCOS as this isolated ovary thing. And even the name, which needs to be thrown away, it's the cysts are just follicles that are growing and not releasing. The core is the hormonal irregularity. So what you have is a vicious circle where there's really severe insulin resistance, insulin levels go high, there's a cascade of problems, genetics, lifestyle, et cetera, that play into this. And then the high insulin pushes the ovaries to make more male hormones. The woman then has these symptoms where 80% of them will be overweight, 20% will be thin. They have excess male hormones, so they'll have facial hair, acne, huge rates of depression, anxiety, emotional effects of this. They get irregular cycles, so their period doesn't come. And then when it comes, they hemorrhage and they have bleeding, and they're using ovulation tests to know when's the right time. And they're the one woman who gets a false positive on their ovulation test. So when they think they're ovulating, they're not. And so unfortunately, OBGYN has treated this very often by the symptom treatment, which is giving people birth control pills. And then I always say you can tell you got a skinny doctor because the advice they give them is, hey, go lose weight, eat less, move more. And when you've done that, come back, and then they give them some pills, Clomid or letrozole, doesn't work, they do IVF, but they're set up for a lifetime of metabolic problems. They have increased uterine cancer, heart disease, Alzheimer's, fatty liver. Every body system that you can imagine is affected. And so what I've learned is I became obsessed with this interaction between insulin resistance and PCOS decades ago. Do you remember Dr. Atkins? I met Dr.
Oh,
Atkins
wow.
of the Atkins diet, and they were using low carb diets to treat obesity and diabetes. And I had just learned that insulin was part of PCOS. And so we started trying this. This was back even before I was at Yale, and I saw results. And the mainstream was saying, that's crazy. Like, you can't treat this with diet, and you got to eat heart healthy grains and have your food pyramid. And people were getting sicker and sicker. So if you look at our country, obesity is like 50% plus of the population. Diabetes is at a record high. Heart disease is a record high. And what's happening in reproduction? PCOS is going up. It's the same thing. So what happens is this woman has a genetic predisposition, and then you layer on it our horrific American diet of processed carbs and fats, and it increases insulin resistance. So we turn her ovary into a male hormone producing androgen machine. It increases inflammation, and you get sicker and sicker and sicker. And then what people don't realize is it doesn't just block ovulation, but it actually makes the egg quality worse, the embryo quality worse, implantation worse, and miscarriage go up. So what I started doing was I was learning from the disciples of Atkins and the low carb and the ketogenic communities who challenged the diabetes world. They said, diabetes is for life. You'll just get it. We'll manage it with insulin until you die of it. Tough luck. And then there was this community saying, wait a minute, if carbohydrates and insulin resistance, if you make insulin from eating carbs, what happens if you stop eating carbs and then you get rid of the insulin? Could you reverse it? They reversed diabetes and got people off of their diabetes medicine. So I modified that to PCOS, and I and others, we see remarkable results where people can start to ameliorate and even reverse their PCOS. We have people who have had 8 failed IVFs that within 2 months ovulate on their own and get pregnant spontaneously.
Wow. That's so satisfying.
The idea is that by treating the insulin resistance with a comprehensive lifestyle program that's not just eat less, move more. You know, if you tell someone who's overweight, like I've been really overweight and I've lost weight following the same kind of program, you have to give people the guidance. They don't know what's not working. So we use a lot of sensors. We use continuous glucose monitors on patients. We do a lot of extensive blood tests for subtle insulin resistance and for inflammation. And we have people and we coach them. We have health coaches where you're going to a party, you don't know what to eat, you're stressed out. Why are you eating? Well, most people aren't gaining weight and eating to excess because they're hungry. It's stress, it's habit, it's lifestyle, and the foods that our system has told them is healthy, this pure carb and low fat diet is really detrimental for insulin resistance. So we guide them through a process where you can follow your blood sugar in real time with a CGM. We have a coach that helps you if you don't know why you're not losing weight. And instead of doing 6-month interventions, we see people turn it around literally in 4 to 6 weeks. We have one person, she's pregnant now. She maybe hasn't ovulated in 10 years. She was diabetic. We dropped her blood sugar 100 points in 1 month and got her off her meds, and now she's pregnant. But you need someone to guide you. Otherwise, there's so much noise on the internet. Eat this, take this supplement. There's 36 supplements that all help insulin resistance, and there's 25 different diets. You got to find one and have someone guide you when it's not working to know really what is the path to success. So that's what we developed. What I worked on was, I had been doing this for my patients.
Yeah.
I was doing this for the people who were coming to see me for second and third opinions after failed IVF. And we said, let's get you metabolically healthy. And I was seeing all this information online. And one of my patients said, why don't you start talking on social media? Why don't you help educate the patients? So I did it. The post went viral, got a couple million views. And now about couple years later, I have 650 million views of my content, 600, maybe 700,000 followers. And people start saying they were getting pregnant just by watching the content.
Yeah.
And they said, could you put this together into a program? So what we did was I put it together into a remote PCOS program where we separated the lifestyle and the intervention from the IVF. And that's the remote portion that we now have that's called the PCOS to pregnancy protocol.
Nice. And then what are your favorite tests to order for someone when you mentioned insulin resistance and inflammation?
So I think that every woman who's worried about this, there's things that they can do on their own. There's a lot you can do for PCOS self-diagnosis. So a woman, you can now see, do you have elevated male hormones with acne or facial hair? They can self-diagnose that. They can see that their cycle's irregular. They can self-diagnose that. That gives them 2 of the 3 diagnoses. Now, then you needed an ultrasound to pick up polycystic ovaries. Now an AMH level can be a good proxy for that. But for the inflammation and insulin resistance, what we usually do, doctors do, is a fasting blood sugar. That's not going to be abnormal until you're diabetic. So you should have a fasting blood sugar and a hemoglobin A1C to make sure you're not diabetic today. Every woman should have a fasting insulin, and then they can calculate something called a HOMA-IR, which takes their blood sugar and their insulin and starts to tell you, are you insulin resistant? We're very avid users of C-reactive protein and sed rates that looks for subtle inflammation. We do a lot of other metabolic markers of inflammation, but for insulin resistance, those are the best. But the tool that I love the most is continuous glucose monitors, because people, even when they're normal, they'll see that their blood sugars are spiking up 100 points and staying up for four hours. It's a great tool to modify your own blood sugar, and you don't need a prescription for them anymore.
Nice. So if a patient is, let's say, seeing me for IVF or another fertility doctor, they can reach out to you for this program.
Yeah. So what we do is it's available online at PCOSbaby.com. We have a lot of patients who are doing IVF elsewhere, and their doctors reached out to us and said, could you do the lifestyle dietary coaching as part of the IVF or IUI process? So we have a whole group of people who do the program who are just trying to get pregnant on their own, maybe failed IVF and are trying on their own, or they've never done medical treatment and they're trying on their own. And then we have a whole nother group that are going to see their local specialist that is managing the IVF, but they want to get that insulin resistance down. They want to get the inflammation down, and they want to be coached through exactly the dietary interventions. We can do that in 1 to 2 months. We see the dramatic improvement.
Oh, that's great. I'm so glad you shared that with me. I didn't know, and now I'm going to share that with my patients. And then when you see patients, I imagine you spend a significant amount of time on your consults, reviewing the patient history and also talking to them when they're partnered about their experience, goals, and barriers before testing even begins. Why is that so important to understand?
It comes down to this idea of the fertility deep dive and the diagnosis, and also the pathway to success and the goal. Patients need to be a partner with the doctor in this journey. So whether you want 4 children or 1 child, whether you don't care how long it takes, but you need to have it within 3 months, what's going on in your life, what are the issues that guide your path? So that's a whole discussion. And because I can give you 3 different pathways to pregnancy, but the one that's right for you in terms of aggressiveness and time will be different. But then the time comes also in doing the analysis of everything that's come before, looking at all the testings, reanalyzing the root. A lot of it is looking at ultrasounds and x-rays, looking at the raw materials. And when they're not done by specialists, they say they're normal, but there's a giant hydrosalpinx. They say you had an ovulation cyst, but it's a big endometrioma. If no one questions the woman about her painful periods and her pain with intercourse, then the signs of the endometriosis have been missed. So by spending the time to go through this, and unfortunately our field is turning into something, I know that you don't believe this, you practice similarly to I do, but our field's going into how can we just deliver more IVF cycles faster at a lower cost? And what I always say is, how can we deliver the best IVF cycle and do once? And so we're getting to something where there's a lot of AI questionnaires and a lot of check boxes done by non-physician providers that then come up with tests that are not reviewed by a physician, and then you go on a protocol plan. I really believe that we need to gather the data and analyze it all together to make the best diagnosis and treatment plan.
Yeah, we are very like-minded. I mean, my approach to care is, what can I do to fix the problem you have so you don't need IVF? And then if you do need IVF, if I only get one chance to do it for you, how can I optimize it so that we don't go through a cycle and say, oh, I wish I had known that first. Obviously, there are things that we learn through an
Right.
IVF cycle that we have no way of knowing ahead of time. But I'm glad you're sharing all of it.
Again, all these things, there's so many things that when you see patients for second and third opinions who come see me, and I'm now licensed in almost every state, so we start virtually, and then people come in to see me in person. We have a situation where they'll say, well, why didn't my doctor mention that test? Or why didn't they look for that? Why didn't they ask me if I have pain with sex? And so there's some things that you'll never find out till the end. And other things that I say, we just spent an hour talking. Had I not looked for any of these things, we could have been done in 5 minutes and you'd be on a treatment, but the treatment wasn't going to work. So I'd rather spend the time and do it right.
Right. And you mentioned looking at x-rays, ultrasound, and you're known for advanced imaging and then also surgical visualization. Let's talk about how that helps identify disease that isn't visible on, let's say, standard testing. Does that change your diagnosis and treatment decisions?
So what's changed over the years is it used to be a lot done at surgery. When I was at Yale, I did the first high definition surgery, the first 4K surgery. And the idea was, everyone in the surgery companies told me you couldn't adapt these technologies to medicine. So I went to the Japanese film companies and I went to video conferences of people making movies and said, can I get your camera and then hook it up to the OR? And we did pilots, and then all the surgery companies said, oh my God, you can see endometriosis that you couldn't see. Oh my God, we can see better in the OR. And so it was always in trying to say, how can we see better? And now the surgery part, that's greatly been removed. We do almost all of it now with imaging, with ultrasound or office hysteroscopy, 3D saline ultrasound. And I think the high resolution ultrasound and a 3D saline sonogram and are crucial techniques of looking for fibroids, scar tissue, small polyps, inflammatory irregularities of the lining. But so much of that, when just a cursory 2D scan is done in 5 minutes, if no one's looking, will get missed. So I think the good news is we've gone where we didn't do that with surgery, but we used to need surgery for all of it. We can do a lot of it non-invasively, even picking up endometriosis and adenomyosis. And now if the person has it and they end up needing to go for surgery, the visualization and the ability to excise all that disease is so much better than it was a decade ago.
Yeah. Oh, that's so great. I love how curious you are and how you're trying to change our field. That's pretty cool.
I'm very, very fascinated by sensors now. And so I met with a company in England that has a sensor that's not here yet, looking at predicting cycles. And I said to them, listen, I think this can detect things better with PCOS. So I said, what is it going to take to get this to the US? So if I have to go to London and pick it up, then I'll go to London and pick it up. And now I'm testing the sensor.
Oh, so cool. Yeah. I mean, I have the Aura ring. And there's a new ring that's coming out that I've pre-ordered. I'm thinking the same things as you, but it's probably not the same one because they're not.
There's so many. There's so many. We're gonna be able to do so much more non-invasively than we could do before. And so right now we have glucose monitor, continuous glucose monitors, continuous insulin monitors, and continuous ketone monitors are coming as well. The ability to do hormones, there's a salivary cortisol and a salivary testosterone now. The ability to do progesterone and urinary kits and not just a P stick looking for LH. But where patients have to be careful is there's so much noise. They think I'm a fact finder and then I try to come up with a new solution from that information. But if you're just a researcher, you can go down a rabbit hole where there's 10,000 unproven tests and things and people trying to sell you solutions, and you get things that don't change what you do. And that's why they need a doctor like you or someone like me that says, hey, I'm open to anything new, but I'm going to help guide you of what's just noise and what's meaningfully going to change the bar and get you to a solution. It's all got to be solution oriented.
When you have a patient that, let's say she's ready for IVF and she shows up, but you think maybe something else would be needed first, let's say surgery, metabolic intervention, how do you talk to her about that?
I'm really data driven and I try to give them all the scenarios. I'm very belief in patients' rights and patients make the decisions, but you've got to guide them to make the right decision. So when I was in med student, I had some transformative experiences. I was working on a cancer ward and there was a doctor who was beloved by the patients because he would sit at the corner of the bed and hold their hand and tell them that he cared about them. And he wasn't the best doctor and they didn't survive, but they loved him because he cared for them. And then there was the hard-ass surgeon who just couldn't speak to you like a human, but the guy would die for you if you needed something done. And there's a synthesis when you bring these two worlds together. So what I say to these people is, I'm very blunt. Like I say, you don't want sugar-coated lies. Patients will get upset sometimes because I tell them the truth and say or people in the field, I challenge online ideas and say people got really pissed off. Why? Because I told them the truth. So what I'll say to these patients is, hey, if we don't do this, here's the best case and the worst case scenario, and here's going to be the odds either way. So if you've got this thing, we had this recently. We had a woman who had an adhesion in the uterus, a small one in the corner, and I was like, you cannot go through the IVF cycle if you don't fix this. And she said, I cannot wait any longer because of what's going on in my life. And that's it. And so together I sat there with her and said, here's the odds if you do it and you don't do it. And if it doesn't work, here's the things that could go wrong. And then we helped her make a decision, but she made the decision based on facts. And too often our field, where I criticize a lot of things that I don't like seeing, is they'll say to the patient, oh, do you want IUI with Clomid or Letrozole, or do you want to do another cycle, or do you want to switch to IVF? You tell me what you want to do. Mm-hmm. So did they tell you what's the odds of success with each one? What's the cost of each one? And what's the involvement? So if you take a 45-year-old and you tell her you could do 6 months of Clomid or do an IVF, and you never tell them the odds of success both ways, they're not making an informed decision. You're forcing your patient to make an uninformed decision. So what I do is with these, when there's things that I want them to fix, I kind of give them the here's why I want to do it. I try to convince them why they should understand my path. But if they say no, then I say, great, then let's do it the way that can work for you.
That's so interesting that you said that, because I have patients transition their care to me because they felt like their doctor was asking them what they wanted to do rather than telling them what they thought was best given their situation. And I think what's happening is doctors are so busy, and patients are often made to feel like the doctor doesn't know who they are, what their diagnosis is, what their beliefs and goals are. And that's where patients get really upset and feel like they're lost in the shuffle. So, what I'd love to talk about is emerging technologies and how you evaluate them, and how do you decide when they truly add value for patients versus when they may be premature. And some of the things that I've been doing, I know you do as well, and that's offering patients PGT-P and rapamycin therapy when appropriate. So talk to us a little bit about both of those things. And if you can start off with just sharing with our listeners, what is PGT-P?
So PGT-P, all the PGTs are pre-implantation diagnostic tests where we are pre-implantation genetic testing, where we're testing the embryo's genetics for something to make a decision about what we might anticipate with that embryo in the future. So the one that most people are familiar with is PGT-A, which is for aneuploidy, which is looking for a whole or partial missing chromosome. It's the number one cause of early miscarriage and why embryos don't implant. And the second one is PGT-M, where it looks for what's called a monogenic disease, where there's a single gene, one letter in the DNA code is off. And when that's off, it causes a named disease like Tay-Sachs or sickle cell anemia. So dad has Tay-Sachs or mom has sickle cell. You know that the child's at risk from the carrier screening. The carrier screening tells you the parents may be at risk. And then you can test the embryo and say, this one has it and this one that doesn't. So PGT-P is the next frontier, where mathematical models and huge DNA genetic databases have allowed us to say, what about more complex diseases? So the number one thing that people come ask me about is always, what about autism? What about depression? What about diabetes? Those are these complex diseases that aren't caused by just one gene. They're caused by dozens, sometimes hundreds. But for a number of years now, there have been mathematical models for adults predicting how well can you predict this disease. There was a landmark study just published for breast cancer saying using these polygenic markers was actually better than just using a protocol mammogram-based approach. They're hugely predictive of risk. And so for years, we couldn't do that kind of testing on an embryo. We couldn't say, for testing for 100 genes, is this embryo high or low risk? So I think when we look at this PGT-P, which I've done it for diabetes for about 3 years now, or almost 4 years, and now we are offering it for the more complex diseases, it's very important when a patient looks at a new technology or doctor, you have to really look at what is all the data, how well does it work? Because there's a lot of treatments put out that are unproven. And then I say to patients, this is unproven. This is experimental. Then there's ones where there's early results, and we say the early reports say we have this kind of benefit and this degree of uncertainty. So with PGT-P, I've spent almost several years following this data with data scientists. And in adults, I think the models are there. And the ability to do it in embryos. So the important thing with PGT-P is it does not say this embryo has schizophrenia and this one doesn't. It gives you a relative risk. And those risks are dependent upon the family's history. So if your parent has schizophrenia or diabetes or autism, you have significantly higher risks of those than if no one in your family had it. If two parents have it, you have significantly higher risks. And the more embryos you have, the more you have to choose between. So you could have something in Alzheimer's where with a family history, one embryo could have a 40% lifetime risk, another one could have a 10% risk. But it's not saying that's 40% chance that they have. It's predicting what's the relative risk. How much does it go down? So if you have something that's 1 in a million and you cut it by half, that's not going to change a lot of lives. But if you have If you have a breast cancer gene where there could be in PGT-P for breast cancer, some of the predictions are saying with a mother history, there could be a 30% risk of the highest risk embryo and a 10% risk with the lowest risk. So those are big changes. And then what I would do with the patient then is the importance with this is you counsel them about really what are they at risk? And very often we're doing whole genome sequencing on the parents as well, uncovering things that they may not know they're at risk for, and then say, which of these would be meaningfully important for you? Then people criticize it in some of these professional societies saying, well, what if they don't have enough embryos? You're not going to be able to pick. Absolutely. And I counsel them beforehand. It's going to be expensive and they're going to have to pay for it. Of course, they need to know that beforehand. What if it's unfair and some people can prevent cancer and other people can't? Organ transplant and cancer treatment and IVF, a lot of people can't pay for. So you can't deny people treatment because we can't deliver it to 100% of the population. That doesn't exist in healthcare. So for this, my feeling is most patients don't need or want it, but the ones who have a family history, they are screaming for the ability to reduce this. And there are ones where they don't have a child because they're afraid of that risk. Mm-hmm. We've had people have a nonverbal autistic child that's so disabled that they say, I'll try to have a girl because the risks are somewhat less. That's a shot in the dark compared to doing potential genetic screening. Or schizophrenia. I've seen people use a donor gamete because their mother had schizophrenia, was institutionalized. Our responsibility is to not just say this thing works. It's really to say this is an unproven technology and here's the potential. And then if the patients are smart and you give them the tools, they'll decide if it's right for them or not. And I don't like where a group of people tries to say, since we don't have the answer, no one can do it and no one can talk about it.
Right.
So I would totally be open to discussions and debates where people say that science doesn't work, it's too expensive and you shouldn't do it, maybe it's unethical to do it. Great, let's have those debates. But we do gender selection. We pick boys and girls, and that's ethical. We let a celebrity use a surrogate when she doesn't want to be pregnant because she's on a movie set. So is telling someone that I could reduce potentially their chance of having schizophrenia unethical? I think to not have that discussion, we're in a world where you can't shut down innovation and you can't shut down discussion. And that's what I do online is I'd say, here's the information. Let's all discuss it openly. I don't have the answers, but I want to have the discussion.
Yeah. For me, if there's a test that's available that a patient could benefit from, I think it's important for her to know, because I would feel bad if a patient had a baby with a certain condition. And if I knew that there was a test that could prevent it, that would keep me up at night. So now that there is, I feel like patients can't give informed consent to choose PGT-A for themselves without knowing that PGT-P is also available. So I think it's wrong that doctors aren't at least offering it to patients so they can make the decision for themselves.
There's so much that we do in our field that is unproven. And I think the problem is a lot of people haven't read the science that this is based on. And they think this is just a company that invented it today. And they don't realize that it's based on a decade of genetic prediction in adult medicine that's transforming how adult medicine is done. Mm-hmm. And so as long as we're honest with the patients about what we know and what we don't know, the patients who are facing these things, these are chances that a lot of them are willing to take.
Right, right. So let's talk a little bit about rapamycin. I mean, rapamycin's also experimental. Not a lot of doctors use it, but there is research showing that it could be beneficial. How do you pick a patient that could benefit from it?
Yeah, so I like to always share with patients. I give like the levels of what we know. I say, here's your diagnosis, here's your treatment, your history, and here's your prognosis. And here's the first level, here's the standard treatment that we're going to do. And it's going to give you these odds. And here's stuff that is controversial. And here's the best case and the worst case. And here is the cutting edge of what is unproven and controversial, but the ones where I think there's promise. Now, there's a lot of stuff that's out there that I think is BS. And I'll say, and here's the things that you're going to read about online and why I don't believe in them. So for rapamycin, this is a drug that was originally used for immune suppression, found on Easter Island in the dirt. Easter Island was called Rapa Nui, and it was in the dirt there, and it was used as an immune suppressant, but it is the darling of the longevity community because it is got one of the biggest promise of extending health span and lifespan in every organism tested. And the way our FDA is set up, longevity trials can't be done because there's no outcome. So I'm very involved with the longevity community and the biohacking community. It's with the sensors, and a lot of them were using rapamycin for years and years and years. And I became intrigued in, could this potentially, it made sense that it could delay ovarian aging. And I know you and I have talked about this. There's a big trial going on called the Vibrant trial that said maybe it can delay ovarian aging 20%. So that's for extending the age of menopause. But for fertility, a lot of things that people are confused about is it doesn't act as an immune modulator. It's regulating protein synthesis and the balance between sort of the drive and production of a cell and the rest and reset and repair. And the idea is as these cells get older in the ovary, there's a dysregulated growth, and the eggs that could have been normal become abnormal. And by damping that down, the eggs can become more normal. And the challenge, and I give you kudos for being an early adopter when we didn't know, was what if something goes wrong? What adverse effect could this have on a developing baby or pregnancy? And we have to tell the patients, we don't have long-term data. Here's the observations that people like you and us and others have done, saying, here's what's been seen. And then a big trial came out of China. But I know the authors, this was a landmark trial done really rigorously, where they did basic science and then they did a placebo-controlled trial, and they had significantly greater pregnancy rates in women who were poor prognosis that had failed before because they had more normal blasts by one. The controls had none. The people with it had one, and they had pregnancies. So rapamycin is one of the ones where I used to use it just to say to patients, like, your egg donation seems to be your only option. So now would you try this? And now anyone where I think that they're a poor prognosis, where they may not get something that's normal, or they may not get another, I think now that we have a published study, we have an obligation to tell them that this is an option. And I have patients who I think absolutely benefit that say, I only want to do what's FDA approved standard therapy with 30 years follow-up. I tell them, this isn't for you.
Right.
But the other ones who say to me, I'm willing to try anything as long as I understand the potential risk, then it is for them. What's you have such a vast experience. I mean, so many people have been guided by you in this. What's your take on how do you counsel your patients to say the degree of benefit that they could get?
Yeah, I mean, I think it's significant. I think at least 50% will see an increase in their AMH. As far as difference between non-rapamycin users and rapamycin users, I think also I just submitted, it was accepted to PCRS. I had a case series that I submitted, and the blast formation rate was like 70% difference in before and after. Euploid rate was at least 40% different. It was like
exactly what they saw.
And are you ready? 3 of them were 45.
Yeah.
I have more patients who are 45 years old pregnant today than I ever have before. And that's because of rapamycin.
Right. So that's why. So now what shifted since this publication came out, and now we've got more information, is now I'm more comfortable saying it to people. What started, it was like I was offering it only to the people that were the last resort. Right. Now I think it's part of every discussion where you might not, where they're older or you may not have good results, saying, hey, this is out there. You know, how far would you go? Right. And are you using it? And I'm sure, I know you are now. I mean, using it for people, the first tries.
First tries, absolutely. Right. Even for my egg freezing patients. Yep. I have one patient, she had done 3 egg freezing cycles before meeting me. I put her on rapamycin. In her 4th cycle, first with me, she got more eggs in the 3 egg freezing cycles combined in that one cycle.
Right. So it's basically anyone that may have a lower prognosis should be on the radar screen to consider this.
Yeah. I predict also, I hope this happens, is that, let's say, once you turn 35, if you haven't had kids yet and you're still considering it and you're taking birth control, maybe even put it into the
Yeah.
placebo week,
Yeah.
just once a day for 7 days. And that might actually, there's some evidence that episodic use might just be as good as continuous use.
So this is really important for your people watching this to know that we are not clear on the dosage of this yet. So
Right.
there are different regimens. There's one regimen where it's used daily, one where it's pulsed weekly. There's studies using it in elderly people trying to potentiate the immune system, where they were using it at a certain dose, and then at a higher dose, it shuts the immune system off. The key things here, people always ask, how is it like tacrolimus or prednisone or Lovenox? We're not using it here with the immune system being the target, but the dosage really is unclear and is being tested and needs to be titrated for patients. And an important thing is it does block muscle protein synthesis. So anyone who's on it really should be supplementing protein and doing resistance training, or else they're going to start, especially if they're on it long term, it has an adverse effect. And too many women avoid resistance training, and they're afraid that they're going to get big. If you go to a guy in the gym and say, could you get big if you weren't trying? They're like, oh God, no, like you have to take testosterone to do that. So resistance training is so beneficial for women's health. Like in our PCOS patients, muscle acts like a sponge for insulin. For longevity, it's one of the best predictors of longevity. We have lots of high success women that spend their days on the treadmill doing cardio, but they're afraid of getting muscle. Protein intake and some resistance training is so important for female reproductive health.
Yeah. I have my free weights right next to my desk, and in between patients, I use them. And a patient of mine, she taught me about these bracelets. They're 2-pound bracelets to put on my hands too, when I can throughout the day.
So as part of our program, part of their PCOS program, we have a thing we call it exercise snacks. Like if you've never exercised, people think, oh, I got to go to the gym for 45 minutes and kill myself. If you are sedentary and not moving, here's 2 things that people, like this is from my PCOS program, but it applies to everyone. If you're sedentary and not doing anything, if you spend 5 minutes a day doing resistance training, which could be sit up, push up, a plank to failure, that could take you 1 minute. If you add that 3 times a week, the effect on your overall health is astronomical. So you don't have to run the PCOS out and bike it out to where you're not sweating out the calories. You're changing your metabolism. Right. So by not eating carbs and doing on ketogenic diets, we're changing people's metabolism. But there's this thing called zone 2 exercise, which I'm sure you know, which is where you're exercising to where you're just slightly out of breath, but just a little bit of effort. That is the sweet spot for mitochondrial health, for fat burning, for insulin resistance reversal. If you do 20 minutes of zone 2 or 5 minutes of resistance training, you could dramatically increase your fertility and how long you're going to live.
That's so true. And with so many of our patients coming in at 40 for their first baby, we want them to live forever so they can see their grandkids. So I want to talk a little bit about learning from every cycle. And you talk about repeating the diagnostic cycle and treating each attempt as new data. How does that mindset support patients after failed cycles? And if they're not seeing the 2 of us, how can patients go back to their doctor and have them do this?
So we always ask, what could have changed? And they always say, oh, they didn't check my tubes because I had a pregnancy 10 years ago. So, well, they check your husband's sperm count? Yeah. Why? Because it could have changed. Well, could your tubes have changed in 10 years? Well, they didn't think of that. Yeah. So I always ask what could have changed and how invasive or expensive or uncomfortable is the test. So I think things related to metabolism, things related to hormones, nutrition, inflammation, ovarian reserve, these should be checked very regularly. Every few months, you should be assessing these sorts of things. Fibroids, endometriosis, scans that are non-invasive, those things change. Oh, I've had a fibroid for 10 years. Right, it was 2 centimeters and now it's 10, but you haven't looked at it. So I think those things need to be reassessed. And if you've had something that should have worked and the cycle didn't work, then I say, go back, and if you haven't looked at all of the raw information the first time around, maybe it's a time to look at it. Like a fluid-filled tube, a hydrosalpinx,
Right.
most commonly missed things on x-rays because they were read as normal. So the challenge for the patient, I think, is to go back, is to get a list of the basic diagnostics and just say to the doctor, which of these things could possibly have changed? I'd be willing to reassess those.
Right.
And then always say to them, is there anything that we could have not understood about the cycle that we understand now, having done it, that would lead to a change in plan? And if they don't want to have that discussion, then you're in a place that's really just following a protocol.
Right. Right. And then your promise is to stay with patients until answers are found. And I know you're obsessed with your patients and their success rates, as I am. It's deeply personal work and we're so invested. What does that commitment look like when you have someone who's been with you for a long time?
It's, one of the patients said to me, she made a video. She had been, I think, in 10 different, maybe 10 different countries. And she said, you walked with me on this journey.
Yeah.
And it's just saying to them here, it's guiding them as a partner, saying, there may be these things you have to go do and get fixed, this surgery or this other treatment, or we're going to try a new protocol. But I'm always going to say to you what I think is where you're going to be, and if we should try again. Sticking with the patient means having an honest conversation with them about what we know and what their odds are and what their alternatives are. Because I say, your goal isn't to be doing treatments with me.
Right.
Your goal is to be getting pregnant and having a success at the end.
Right.
So it's me guiding you to the path to success.
Yeah, I love that. For listeners who want to learn more about your work, your PCOS programs, or care with you directly at Gold Coast IVF, where's the best place they can find you?
So I'm on all social media, Instagram, TikTok, Facebook. I gotta say, I can tell the age of my patients based on which platform they see me. As I said, it's almost 700,000 followers. It's at Stephen Palter MD, STEVEN PALTER MD on every platform. I read the comments, I respond to them, I do DMs. Gold Coast IVF is the practice if you want to come see me in person, either virtually, remotely, in person in New York, or start virtually and end here. And if you want the remote program, PCOSbaby.com, you can start whether you're doing treatment on your own or with a fertility center. We'll guide you to our metabolic reset.
Awesome. Thank you so much. Is there anything else you want to add today?
I think we touched upon so much. I just thank you so much for having you here with me. It's been a pleasure chatting with you. And I know that we share such a philosophy on how we approach innovation and care for our patients.
Yeah. Thank you so much for joining me today and for the work you do on behalf of patients all over the world. For everyone listening, links to everything we discussed will be in the show notes. Be sure to subscribe to the Egg Whisperer Show on YouTube and Spotify so you never miss an episode. And remember, no matter where you are on your fertility journey, keep asking questions, keep advocating for answers, and keep sparkling.